had a test. Yeah,
Well, that's right. You had October break.
All my teachers except for you do not post grades. I'm like, how do I know where I stand in the class if you don't post grades?
You email back. He's really good at getting back to you. Yeah.
I'm like, seriously. Took
I
me 5
email-
days to get back to me.
I email him in the parking lot. Yeah. When I leave, and he usually is really good. He gets back to me. Because he knows I'm neurotic.
My teacher. I don't care what he did. Just like he doesn't care what I do. He doesn't. It's true.
I know, but shh.
Let it know you're on.
I'm on.
He's a wonderful teacher.
No, I can. He's a wonderful teacher.
And sometimes, you just have to. And sometimes when there's something like that, let somebody know. See, because all right, chapter 22. So, chapter 22 is the respiratory system. And what's it for?
Lungs.
What is it for?
Exchange gases.
That's what I want. Exchange, because I always say, well, it's for breathing. Well, what's breathing for? Why do we breathe? Well, we breathe so we don't die because we aren't able to make enough energy. So the key here is this is a group of organs in the human body that is going to help by bringing in atmospheric gases and to help with gas exchange. Gas exchange, the two main players here, oxygen, carbon dioxide. Okay? And that's what all of this stuff is for. Now, another question, and I always get the same answer. Breathing, how does it happen? So it has something to do with air pressure. Like what air pressure?
Well, when you open your mouth, you're breathing in the air around you.
Yeah, but how are you breathing? Why are you breathing?
Your brain is sending a message to your cells to get your lungs.
How does that happen?
The pressure lowers in your lungs and then the air rushes in to fill it.
Why does it do that?
Because of the diaphragm and intercostal muscles, they change when you take a breath.
What do you do? Think about taking a breath in. What do you do?
Diaphragm is you have your diaphragm.
And you?
Increasing the volume.
Increasing the volume in your thoracic cavity. That's what I want. Increasing the volume does what to the pressure? Lowers it. Where does air want to go? From a high pressure to a low pressure. So in order to breathe in, get the air into your body, you have to use this apparatus of little things in your thoracic cavity to change the pressure, lower the pressure. That's why you breathe in. What do you do when you breathe out? And what does that do to the pressure in there? So if I take the same amount of tea in my container, and I then all of a sudden make the container smaller, what do I do to the pressure in the container? I increase the pressure. Now what's the air want to do? Go from a high pressure to a low pressure. So that's the mechanics of breathing. So all of these guys are the functional anatomy of doing that. Pulling air in and pushing air out. Now there's a whole bunch of tubes, but the business end, and what's the business of the respiratory system? What's it doing for me?
Exchange the gases and take up oxygen and rid of carbon dioxide.
So that's the business end. This is where what we want to accomplish in the respiratory system happens. Where is that? It's inside the lungs, way, way down deep in the lungs, around these tons and tons of little balloons called alveoli. So the goal is to get the air down to the business end, and the business end is called the respiratory zone. So this is where gas exchange is going to take place. Yes?
It's far away from that what we talked about. But just since last night, because I watched the interaction physiologist, I have a question about why is it when we breathe in, why the pressure is actually negative? This is what I don't.
Well, it's a lower pressure or a negative pressure compared to what's in the atmosphere.
Well, compare with the atmosphere.
And that's lower, negative, move. We move towards negative pressure. If I didn't create that, it's almost like a suction. If I didn't create that negative pressure, I wouldn't be able to breathe in. So when you...
Negative inside and outside, so the pressure goes...
Right, and if inside the thoracic cavity, we're going to see all of these organs that I'm going to talk about in a minute, create that negative pressure, that suck, that vacuum. If I poke a hole in it, can I create that pressure difference? What's that called? There's a fancy science name for it. Pneumothorax. So when I disrupt the container that we're going to talk about in a minute, I can no longer create negative pressure. The pressure is equalized. Is the air going to go in and out? No, because air wants to go from a high pressure to a low pressure. If I don't create it...
That's why it's negative inside and then
Correct.
positive
Right.
when we breathe out.
Correct. We're going to talk a little bit about some things in chemistry, a couple of little laws, Boyle's law and Dalton's law, which we'll talk about in this chapter, but based on those principles. So you're actually going to learn a little physics. Scary. So these are the parts. We have to know the parts. You'll see that diagram again somewhere, probably on your next lab exam. And all the parts associated with the respiratory system. The other parts, all of the tubes that lead down to the business end, that's called the conducting zone. So when I breathe in a certain volume of air based on how big I can make my container and how stretchy my lungs are. But does all that air go down for gas exchange? No, a lot of it's stuck where? Yeah, it's in all those tubes. So what's happening in the respiratory zone is only happening to a small volume of the air we actually breathe in. So we have a nose that sits on the outside of our face, external nose. What's that doing for me?
Filter
And actually, think about air coming in. It's going to start air bouncing. Exactly. Can I breathe without a nose? Yeah. No, you can breathe through that space without a nose. Yep. You can breathe through your mouth because you have a shared path. It's just to start the air bouncing around and someplace to put your glasses. Yes? So it's not vital, but it's going to start the process. The bouncing around part, why do I have to do that?
filter from bacteria, from
Not only filter, but when I move things faster, what happens to them?
flesh.
They get excited. Think temperature. They get warmer Because for maximal gas exchange, not only do I want to get the air down there and I want to make sure it's filtered, but I want to warm it up. So bouncing it around like that as I bring it in the beginning through the nares of the nose and bounce it around in that nasal cavity. And when you did your skeletal system, you talked about all those little folds that were in your ethmoid bone and your inferior nasal concha. Remember that? All those things were there to do that, bounce the air around. Now they're covered with mucous membranes to do what? Moisten the air, because I need it to be in a little bit of a fluid medium for gas exchange, and to filter the air, because I don't want anything from the environment getting way down into the alveoli. Alveoli are microscopic. You have to look under the microscope to see them. So they're very, very small. They're covered with capillaries for optimal gas exchange. So the next, behind the nose and the nostril and the nares, we have the nasal cavity. That's where we find, what else do we find? We talked about it at the beginning of the semester.
Hair.
You got hairs and you got mucous membranes and you have what? Olfactory. That's where your receptors for what are? Smell. I hope you don't taste with your nose.
Well, it does help, right?
Well, the processing of information about taste involves information from smell as well. So we have our nasal epithelium in there with our little receptors, olfactory receptors as well. And when I bring in the air, because of the way I bring it in through the nose, it bounces to the top of that space, and that just happens to be where our olfactory receptors are. As we work our way down past the nasal cavity, we're going to hit the top of the roof of the mouth. Now, we're going to send air down a tube, back of the throat. This tube is shared. Shared with what other system that we're going to talk about this semester? With the digestive system. So once I hit that top hard palate, soft palate, I'm going to go past it. And this diagram is a little bit better to see. And I'm going to enter the next part of the tube, the pharynx. Now the pharynx, because it's shared, actually comes in 3 different parts. We name it 3 different things depending on where it is we're talking about. The part of the pharynx that's behind the nose or nasal septum is called what? The nasopharynx. The part that's behind the mouth is called the oropharynx. And then the part that's behind this area here, and does anybody know what that is? The larynx is the laryngopharynx. Okay? So we see it's named pretty much for where it is in its destination. Esophagus.
Esophagus. It's actually the smaller tube than trachea.
Yes, but it can get big. So when you think of the trachea and the esophagus, we're going to see the trachea is a tube that's held open, and it's held open with cartilage. The esophagus is probably about the same size tube, but it's not held open with cartilage. So see what happens to it? Now, why do you think I have cartilage on the trachea? So I can breathe. So the tube never does what? So it never collapses. Because the only thing I'm sending down there is what? Air. Hopefully no cheeseburgers or anything like that, right? But this guy that's kind of folded up right now, that's going to get what? Food. So when I swallow, what happens is this. It's going to stretch out. But notice, because of those little C-shaped rings in the trachea still never really closes off. When we swallow, we don't breathe, but we still don't want it to collapse on itself. Because it's just like one of those little wet balloons that kind of gets sticky. You ever give a little child a balloon? And they blow it up and they let it go, and they blow it up and they let it go, and after about 3 hours of that, it gets all crusty and nasty and stuck together. We don't want that to happen to the trachea. Since we're sending food down the esophagus, that's going to stretch it out as we go. We'll see there's different linings too.
When we accidentally, like swallow, not swallow, I think like something
Gets in your windpipe.
in the trachea.
Mhm.
What's happened next? Where those food or those particles?
What do you do?
What?
What do you do when that happens?
Yeah.
Hard, right? And you're going to keep doing that for a long time.
Yeah.
We're going to, Hairball. You keep doing that for a long time because what happens is those particles, there's little cells right here, as we go down the trachea and it branches off into the bronchi, there's little cells there that are going to detect any particles. Those cells are called, they're in an area called the carina. They're part of the nervous system. We'll see it on the diagram.
They're like macrophages?
No, they're just going to detect particulates. So they'll make you start to cough. When you go to the store, say you have a cough, you go to the store, you buy what? You buy some drugs, you buy some cough suppressant. What do you think that does?
They suppress the carina.
It suppresses the cells and their activity so you can stop coughing. Now you're coughing typically because there's something there that's aggravating those cells. But unfortunately, sometimes when we get sick, it can do other things and drive us crazy. So a cough suppressant does that, suppresses those cells.
So in an ideal situation, you don't really want cough suppressant because you want to cough that crap up.
Unless you're coughing it starts to become out of control, kind of like the temperature thing. The temperature is doing something for you, but once it starts to become out of control, it's actually harming you rather than doing you
I
good.
had a pediatrician tell me for my stepdaughter not to give her Tylenol for a fever because it's her body fighting.
Yeah. And it's low grade. Once it starts, and the problem with children, and this is the scary part, is they can fluctuate so fast. And then, have you ever heard of a febrile seizure? Yeah. So sometimes that can happen. So that's touchy with kids. You have to, I say, if your child tends to do that, or if it starts to climb really high, then give your child some. And again, different system, different reactions, so you have to be careful. Yeah, but again, that's a hard one.
The worst part is just that they're so like lethargic and you can tell they feel crappy when you go give them something. And
Right.
The minute that ibuprofen kicks in, most of them are back like
Bouncing around,
they're
yeah.
like, I want to play now. Like, no,
Yeah,
you were
'cause
just sick 5 minutes ago.
Yeah, and when it wears off, you're going to be sick again.
Uh-huh.
So yeah, you got to be careful with those. All right, so they talk about the nasal concha. They talk about the paranasal sinuses. What are the sinuses for? I don't think they have any in. There's not in this diagram. Do you remember it from? In the frontal bone and the sphenoid bone and the maxilla. Remember you studied that last semester?
But we didn't study the sinuses, though.
Yeah, you did. You better have. In bone. When you did bone. Yep.
When we did bone.
Yep, that's what this is. But what purpose do they serve for the respiratory system? There was some fluid in there, wasn't there? Yeah, it's going to help with the moisture issue. So when you bring in air, you have to start to moisten it as well as start to warm it. So those paranasal sinuses are going to help with moistening air. There's little pockets in there, and there's some fluid. Not a lot of fluid. What happens when you get a lot of fluid? And you get pressure and pain. So they're going to help moisten air as it comes in. So the pharynx, 3 different parts. Nasopharynx, behind the nose or nasal cavity. We see here some tonsil material as well. What's the tonsils for? Oh, part of your immune system. And why do you think we have some there? Yeah, remember the air you're breathing in is not what? It's not sterile and filtered, right? So we want to make sure that we have a member of our immune system, lymphatic system there as well. Then the oropharynx and the laryngopharynx. In that larynx region, there's a very, very important little flap. And it's called the epiglottis. And what's the job of the epiglottis?
Covers the trachea when you swallow.
When you swallow. Because you don't want food to go down the trachea. What's it called when food goes down into your trachea and into your lungs? You aspirate. Why is that a problem?
Because it is allowing foreign particles into your lungs.
Yeah, and what's the matter with that?
Yeah, you can get pneumonia.
Exactly. It can start to multiply bacteria. It can start to fester and cause, or may lead to pneumonia. Yeah. So the larynx and the epiglottis is going to help close off the trachea when you swallow. So when you breathe in, what happens to the epiglottis? It snaps back up. What causes it to close? Do you know?
Probably muscles.
Yeah, muscles. What kind of muscles? Your tongue. Exactly. When you swallow, think about what you do when you swallow. Never really thought about it till now, till she asked me to. But your tongue contracts, pushes the food down the back of your throat, and snaps closed that trap door. Some of the problems as we age or with some different diseases, and you probably might have, if any of you work in hospitals, what do you have to do to some patients? Thin liquids. You have to add thickeners to them because that epiglottis doesn't shut nice and tight like it used to. So some thinner liquids can sort of leak over the side and cause them to aspirate. So you have to be careful with some thinner liquids with those patients because that whole mechanism isn't as efficient as it was when they were younger, or it might be degraded because of whatever disease they might have. So the larynx is for voice production. Well, why do we talk about voice production when we talk about the respiratory system?
Because we need some air to talk.
Yeah. So try and say something and not breathe out. Say something when you're breathing in. Can you? It's hard to do, right? Because the respiratory system, as it blows that air out, is also going to play the instrument that is your voice. So in your larynx, voice production takes place because air passes across your vocal folds. They're called vocal folds, not vocal cords. And we see them right there. That's a little bit easier to see them. In this picture, where is it? Wish I had I don't have a thingy. It's right up there, vocal folds or true vocal cords. And they run across the tube. So as we breathe out, we breathe air across the vocal folds as well. Depending on how tight or how loose those vocal folds or true vocal cords are, we can do things with our voice. We can make it very, very high pitch or very, very low pitch. We can make, by pushing more air, project our voice with the help of our paranasal sinuses long distance. So when I want to scream at somebody across the room, what do I have to do? Push more air And then my paranasal sinuses are actually going to vibrate a little bit more so that I can project my voice long distance.
Same technique actually for singing.
Yeah, exactly. You need to bring, and that's why singers, one of the things singers always do is what? By doing what? Breathing exercises, or breathing out a whole bunch of air, making sure that they take in sufficient air so they can breathe out a nice volume. When you play an instrument, you have to do that too. Well, if you play a wind instrument, yeah, you're just going to have to blow some wind. I used to play the clarinet, so yeah, it was horrible. I just liked to be in the band. I was a geek. No, I was terrible. I really was. It was. I couldn't. It was horrible. Huh? I still have mine too.
I have mine and I want to give it to my son.
No, you know what they'll tell you when you go to give it to your son? It's not good anymore. You got to go spend some money and buy a new one. Liars.
They are liars.
Yeah, because I bought the new one, and then the second grader, third grader played it for all of twice. So then I had the old one and the new one. So anyways, I'm sorry.
And then you can rent them.
Huh? Now I have a new one, yeah.
And then you can rent them for like a ridiculous
Oh, yeah.
And
Crazy money.
they-
No, you can buy mine cheap. I'll sell it to you cheap.
I don't have
It's brand new.
I played it too, and then when I got to middle school and actually went to band, I hadn't practiced and I didn't know anything, so I just sat there and pretended I was playing. And
Yeah,
then I just
pretend.
dropped- and then I just dropped
It's
the
hard
chord.
though when you're in a small band and they actually expect you to produce some
So
sound.
then
Yeah.
I said, I'm not doing this band thing anymore.
All right, back to voice production. So, larynx, vocal folds, have a couple of different parts. True vocal cords are where we're going to actually produce sound. And it's like a stringed instrument. So the tighter I make it, the higher the pitch. The looser I make it, the lower the pitch. They talk about something called the sphincter function of the larynx. What's the larynx have to do with? Yeah, what's that doing for me?
What's the page?
Oh, we're on page 809. Does the respiratory system help with other things, like maybe emptying your digestive system? Yeah, it does. Yes, when you grunt, and we won't get, yeah, just read it, and we'll go from there. But when you have trouble, especially when you're a little on the constipated side, the respiratory system and breathing and pushing air can help you eliminate from the bowels as well. So that's what they're talking.
Trachea is pulling when
Well, the air pressure, and yes, it'll help you. Yeah, like I say, read it.
What about getting sharp? Like, I feel like sometimes somebody's taking a knife and stabbing me in the stomach. Like,
Oh, from respiratory or from
air. Like, I don't know,
after like running or something like that?
eating or like, yeah.
Sometimes if you eat too much. Too much? I guess I don't understand the
It
question.
hurts wicked bad. Like, I just feel like
Is it pressure though? Is it pressure in your abdominal cavity that's
yeah,
pushing up? Yeah.
it's like really bad.
So you might have gas buildup or,
I guess.
yeah.
I guess I can't get rid of that. But this is gonna sound awful, but I've never burped in my life. I don't know how to burp.
No, you should come to my house.
Like, I don't. And
My mother
it's
could
like,
teach you
that's
how to
not-
burp really
there's no
well.
way you could burp. And I'm
No,
like,
but that,
I
if you can't push air that way, that, yeah.
So, huh? No.
Or she is in pain because she builds up gas in her system.
I can't, yeah.
is it from the study?
Yeah, it's just like, I get these wicked sharp pains.
Do you have a hiatal hernia?
Sometimes, and I'm not.
Do you have a hiatal hernia? Do you know if you have a?
I don't go to doctors.
So you might have one. It's very common in women.
What,
And a hiatal hernia is where the esophagus comes and feeds into the stomach. There's some membranes around there. And what happens with that is the tube sort of pops out and creates some pressure there. And that's what it sounds like. You probably have one. It's very, very common in women. You usually don't do anything for it. You just have to be careful and not eat meals too big, or you might develop reflux as a result of it as well.
See, I have a good reflex. I can put my finger down my throat, not even.
Not reflex, reflux.
Oh, reflux.
So acid coming up on the esophagus. We don't want to have that. That's not good. So yeah, so you might have that. And that can also prevent air from coming up and you burping as well. So that's probably what it is. If I had to take my $75 guess, I say you probably have a hiatal hernia. I'm going 75. I'm not too expensive.
It's cheaper than
Yeah, it's just, yeah.
Maria, how, if you have a hiccup, sometimes when you breathe some air and trying to hold it, that sometimes helps.
It spasms in your diaphragm. That's what causes you to hiccup. Now why? I have no idea.
Something.
Yeah, and sometimes patients who've had surgery, like my father just had surgery on his colon. And one of the things that happened to him was the hiccups. Because they had to put in air into his abdominal pelvic cavity. They were going to try to do it laparoscopically, and that's what manifested in him. So not only was he miserable, but he had the hiccups to boot, the poor guy. There's all sorts of remedies, but basically you just have to stop that. It's a nervous system stimulus to the diaphragm, and you just have to wait till it stops. It is awful, especially when you've had abdominal surgery. Yeah. Well, it yeah. Yeah. Ooh, yeah. It's not pretty. The poor guy. I feel so bad.
So the remedies to stop hiccups are basically just to...
I think what it does is it takes your mind off of them and might calm your system enough to stop the nervous system stimuli. I don't know. Honestly, have no idea.
You're led to believe that
You're distracted from it.
So it does.
Or you get distracted doing whatever it is, and it stops that impulse from happening. Who knows? All right, so what are we looking at over there? Sort of what I described with my fingers a little while ago. The trachea and the esophagus. In lab, you're going to look at some slides of the both of them together. And some of the distinguishing factors of the trachea is that cartilage ring. There's C-shaped rings. And why are they C-shaped rings and not total rings like this? See that? It looks like a U. It looks like a horseshoe almost. Yep. Nope. What's this ring up here?
So your esophagus can expand.
Exactly. It's so your esophagus can expand. If we had total rings, what would happen every time you swallowed? Your whole neck would pop out, wouldn't it? Because that expansion of the esophagus wouldn't have anywhere to go. So we're designed pretty well. Those C-shaped rings are going to help hold open the trachea. So when you look in your slide and you try to figure out under your slide which one's the trachea and which one's the esophagus, what's the difference between the trachea and the esophagus? Well, the trachea has those C-shaped rings. What kind of tissue is that? It's hyaline cartilage. You remember what that looks like from last semester's tissue extravaganza. Remember that? Kind of looked like a skating rink, and then there was big holes in it with the cells. So you're going to see that in your trachea. You're not going to see that in your esophagus. What you're going to see lining the trachea is what? What kind of cells? Lining and covering. What kind of cells? Epithelial cells. What kind of epithelial cells are we going to find lining the trachea? That big-ass word, pseudo-stratified ciliated columnar epithelium. I didn't even have enough air in my lungs to say that whole word. Yes? So what's the cilia for? Help capture any nasty stuff in the mucus that's covering that layer. And then what am I going to do with the mucus after it's trapped all of the nasty particles from the environment. You're going to push, and the cilia is going to push it up towards your mouth. So in any given 24 hours, you swallow a lot. You're not really aware of it until I actually point it out, and then you're like, oh yeah, I just did that. It kind of is subconscious. But you're constantly swallowing that mucus. Unless you're a baseball player, then you're always spitting. Yes? To one thing I hate about baseball, it's like, really? Do we need to spit that much? Is it necessary? So, the cilia on the pseudostratified ciliated columnar epithelial cells pushes up that mucus. So the other thing we find in that layer are goblet cells. And again, this is review from last semester. Those goblet cells make mucus. Yes? Yep. So pay attention to that when you do your histology for the respiratory and digestive system.
Can you please repeat that?
So if you look at...
Can you repeat when we swallow, the esophagus will dilate, right? Or
Well, the esophagus will stretch, yes.
Toward trachea.
Correct. So like this. I can't do it with my fingers, but...
Yeah.
So this tube, the trachea, won't close off. The epiglottis will shut and shove food down the back tube so that food won't go through the front tube.
What's the front?
The front tube. So when I look at the anatomy of respiratory digestive system, the front tube is the trachea. The back tube is the esophagus. So when I look at this, see, that's anterior. I'm looking this way. So the front tube in this diagram is the trachea. The back tube is the esophagus.
Okay. So not only the esophagus will expand and
It'll push into the...
protect from food go to the
trachea.
but also epiglottis.
Right, the epiglottis will do that first. And then you'll shove food down the back tube. So say I'm not a good drawer. So here's my two tubes. There's my epiglottis. There's the back tube. When I swallow, it's going to shut this trap door. So when I start to put food down my throat, that trap door is going to shut, and the food will then go down the back tube. So this is anterior. So this is the what?
Trachea.
That's the trachea, and that's the esophagus. Okay, and then when I breathe again, it's going to open back up. Okay? So it's important to know that those cells, the histology here is extremely important to help keep particulates out of the lower respiratory zone. If I look at the esophagus, and we'll talk about this when we do digestive system, we're going to find different cells. Did you eat breakfast this morning? Yeah, and if you're anything like me, you made a couple of chews and you swallowed whatever it was, probably in the car on the way to work, right? Or on the way to school. Now, the food you swallow, your esophagus is about that big when it's not being used. The food I swallowed was a lot bigger than that, right? So what happened? It stretches it out. So the anatomy here works really well because we don't close off the trachea totally with the tube expanding into it, and we keep it open with that hyaline cartilage. So notice the cells up there at the top, pseudostratified ciliated columnar epithelium with goblet cells. So as we travel further down the trachea, we start branching, and it's called the bronchial tree. Why is it called the bronchial tree? It looks just like a tree. So if I go outside and I look at this tree, this big beautiful tree in the yard here, what I'm going to see is a main trunk. And then as the tree grows, most trees have a split somewhere. Now some have a few more than that, but we only have a split that goes in two directions, right and left. So the trachea, just before it splits, that's where we're going to find our carina. We see that in the last paragraph of the tracheal description on page 809. And again, that's groups of cells that are going to help monitor whether things have gotten down that far. We don't want them to get way, way down. So if we could stop them there, that would be great. If there's particulates there, what am I going to do? I'm going to push them out. So I'm going to push air out when I cough out and hopefully push out any particulates that might be in that area. So coughing is stimulated by the cells in the carina. So there's my tree. Yes? Do you have a question, Mila?
Yeah, what's the purpose of larynx?
The larynx is where I'm going to house my vocal folds. Now, what I do is to protect them, because that's my vocal instrument. This is how I remember it. It's very thick with cartilage there. I don't need any bends there. I don't need to bend my neck at that point. So I'm going to keep it very protected with very thick cartilage. The cartilage is called thyroid cartilage. Why do you think it's called thyroid cartilage? The thyroid sits right on top of it. Yep. As we go down further, I have to be able to bend my neck, right? Well, I can bend my neck, I should say. If I did that and it was there wasn't those little breaks, what would happen? It would snap. You know, I know this happens to me all the time. You go and you get an iced coffee or something, and you get a straw, and then you stick the straw in, and you have to stir it around, and you bend it just enough so it cracks, and then you can't use the darn straw, right? That's what would happen to your trachea if you then didn't have, after we go past the thyroid cartilage, if you didn't have the cartilage rings.
You don't just flip your straw over, then you can use
Yeah,
it.
but then until you hit the brake.
Until you get down below the brake.
Yeah, I know. I've been there, believe me.
Trust me, I have too, kid.
Oh, I'm telling you, that makes me so mad. So, those rings are called cricoid cartilage, and then the ligaments between the rings are called cricoid, or cricothyroid, ligaments. So that's what creates, and the trachea reminds me, have you ever gone to Friendly's and gotten one of those big, thick, bendy straws that change color for the kids? Yeah? Do you know what I'm talking about? Do you know what I'm talking about, bendy straw? You might not have the Friendly's bendy straw, but you've had a straw with the little yeah. That's what the trachea is like. When you dissect, and you're laughing at me now, but when you dissect your fetal pig, you'll say, Maria was right. It looks just like one of those bendy straws from Friendly's, because you'll notice it when you open up the neck. It's going to be very evident. It doesn't change color. I'm sorry. So, bronchial tree. So once we pass down the trachea, the main tube, the trunk of my tree, we're going to go into the divisions called the bronchi. And we have two main divisions there. One's going right, one's going left. The first beginnings of the divisions are called primary bronchi. As we start going further and further, those guys are called secondary bronchi. Now, sometimes they're called lobar bronchi because they happen now to be penetrating into what? Once I start making more branches, where am I? I'm in the lungs. Now, two lungs, different number of lobes. The right lung has how many lobes? 3. The left lung has 2. Usually when someone aspirates something or it gets down into the trachea, the biggest branch goes to the right, and that's usually where things get caught up. I mean, if we're in big trouble, it gets caught up there. How can I get it out? And some of you have probably had to go learn how to do this. The Heimlich maneuver. What is the Heimlich maneuver?
You're exerting pressure under the diaphragm.
When we talk about different respiratory volumes, we'll understand why that actually works. When I breathe in and out, remember the conducting zone versus the respiratory zone, I have a whole bunch of extra air in the tubes. But the other place I have a whole bunch of extra air is in my lungs. Think of that balloon, that little child's balloon. One of the things we're going to talk about in a moment is the respiratory zone, those balloons, the alveoli. I don't ever want those balloons to totally collapse. Because what happened to that child's balloon? It got blown up 14 times. Once it collapses, it does what? It sticks. Would I be able to get efficient air exchange if all my alveoli had collapsed and they were stuck together? So one of the things I do is I never physically am able to blow out all the air from my lungs. That's just the way you're physically set up. You can never make your container that small unless something happens like pneumothorax. And then what happens, and you probably have heard this term, or collapsed lung. Have you ever heard of that? That's when the pressure gradient gets so differential that the air, most of the air comes out of your lungs. And that's what happens to the little balloons.
So like the heart, with air in the lungs, that you breathe in, rotate.
Yeah. So if I was able to take air in the respiratory system and put a dye to it, you would see how it would move around in circles like that, and just like it would through a room. So we start to branch out and we start to hit all of the tissue in the lungs for gas exchange. As the tubes get smaller and smaller, they're going to go from bronchus to bronchioles. So they get smaller and smaller as they run through. Remember, the conducting zone is air that hasn't reached the respiratory zone. It's in these tubes. The respiratory membrane, on the other hand, is the end of the tubes. This is where the little balloons are at the end. Correct. So when we get to the end of the tubes, the terminal, the end, they are the terminal bronchioles. And then we see that the cartilage rings, as we get to the end, start to disappear. And the tissue becomes thinner and thinner and thinner until it feeds into the alveoli. So the respiratory zone consists of those respiratory bronchioles and these little balloons, the alveoli. The other thing we see here are tiny little sphincter muscles that sort of wrap around the tubes. Now those can help regulate gas exchange, air exchange in the tubes. They help to make sure that the balloons don't get too full. But they can also be a problem when we have an allergic reaction and hypersensitivities, which is going to be on your next test. What's one of the things that chemical invasion might do? Exactly, constrict your bronchioles. It affects those smooth muscles and actually causes them to contract. Now that's an issue, right? Because if they contract, then you can't do what? Yeah, you can't get air down into the alveoli, and that can be a huge problem. Anaphylactic shock can cause death because it affects these muscles and doesn't allow enough air to get down for gas exchange.
What's the difference between alveolar sac and alveoli?
Well, a bunch of grapes versus one. So the alveolar sac is a whole bunch of alveoli, and the alveolar one, yeah. So I always think of them as a bunch of grapes because that's what they look like to me. So one grape versus a whole bunch of grapes.
What did you say those muscles are called?
They're just smooth muscle. Sphincter muscle is a muscle that wraps around a tube. I don't think they refer to them. I don't know if they refer to them as sphincter muscles, but yeah. Usually a sphincter muscle will close off a tube. So when we talk about the urinary system and the digestive system, we'll talk about sphincter muscles that close off the tube in different places. So, the alveoli. What I want you to understand are the players in the respiratory membrane. So when we have a close-up look in this diagram, and that's on page 813, of the actual alveoli and what's going on in there, we see that the alveoli are a layer of simple squamous epithelial cells. Remember when you studied tissues way back when? What's one of the slides you looked at? Yeah, you had two. You had one that said simple squamous epithelium, and it was like all the cells all flat. And then we made you look at a lung. No, simple squamous. But the lung was these cells like this, and you were looking at them this way, wrapping the tubes. I mean, wrapping the balloons. So we made you look at them both ways. So simple squamous epithelial cells are the actual cells that make up the alveoli. These guys are called type 1 alveolar cells. There's a couple more things down in those balloons. We're also going to find a bunch of little cells that are kind of like our sweepers, our cleaners. They're called type 2 alveolar cells. No, I'm sorry, the alveolar macrophages, I'm sorry. I'm looking at my diagram and I'm ahead of myself. So alveolar macrophages, there are sweeper cells, just in case any debris gets down there. What else might happen that we have to get rid of down there? These are epithelial cells, right? Are they going to last forever and ever? No. What might they have to do every once in a while? Or they die or make new ones. Mitosis has to take place. So they get rid of any dead, dying cells. So alveolar macrophages. And then the type 2 alveolar cells are there for another reason. Remember that little child's balloon? Well, what's one of the things that's going to help it not stick together when it collapses? Air is, yeah, but what if I don't have any air? Yeah, what if I have a little liquid? Yeah, it's not quite mucus. Believe it or not, it's more like soap. Soap? Yep. It's called surfactant, exactly. And it's slick and slippery and lipid containing. So it's going to help that balloon not stick to itself. That fluid, surfactant, is also going to help reduce surface tension. Now, why is surface tension a problem? And this, again, you're going back to chapter or whatever chemistry was way back then. What do I have to do down there? What's the business? It doesn't have anything to do with muscles. Think of the business end of what's going on here. What do I have to do? Gas exchange, right? Remember when you talked about water and surface tension and heat of vaporization? This was all last semester. Water has a very high surface tension. Yes? In order for me to have gas exchange efficiently, I have to decrease the surface tension so that water is where gas exchange is going to take place, so that oxygen and carbon dioxide can pass more freely in the alveoli. So surfactant is going to help create a slippery surface, is going to help give me fluid for gas exchange, and it's also going to help reduce surface tension of water so that more efficient gas exchange can take place. Well, it's in the liquids that are floating around.
But it's closer to the outer.
Well, where else is there liquid here in this setup? Besides in the surfactant that's lining.
Liquid is everywhere. It's not only the outer surface.
It's lining the surface. It's sort of coating the surface of the alveoli.
Not everywhere.
Well, yeah, it's everywhere behind that, right? Because we have pleural fluid that's surrounding the lung material. And then what else? What other fluid's really important here? Blood, plasma in the capillary beds. Remember, we're talking about a world here that's only 1 or 2 cell layers thick. So if there wasn't any fluid there, what would happen to those cells? They would dry up and die. So we are talking about a fluid, cells floating around in fluid, basically, when we talk about the alveoli and the capillary beds. Okay? So know that type 1, type 2, and macrophages are in our respiratory zones. Understand that gas exchange is going to happen between the single cell layer endothelium of the capillaries and the single cell layer that makes up the alveoli. Remember, those cells are what? Not stratified, simple squamous epithelial cells. If it was thicker than that, would I be able to exchange gases? Just like when we talked about the capillary beds. If it was too thick, would I be able to have gas exchange? So why is pneumonia a problem?
Because it will not let you exchange gases.
Yeah, too much. So it's like taking those cells where gas exchange should take place with that thin layer and now creating a swimming pool on top of it. So now gas exchange can't happen fast enough when my lungs are full of fluid, pneumonia. So infections can cause that as well. All right, so lungs and the pleura then. When we talk about tissues and tissue systems, we talk about lungs, in this case, encased by membranes. And what kind of membranes are we talking about? No, that's around the heart.
Yeah, for heart.
We're talking around the lungs, pleura. So we have 2 different layers, just like we had in the heart. Parietal and visceral, exactly. They're serous membranes. So what's between the parietal and visceral layer?
Full of
Liquid, space. And liquid's in the space. What kind of liquid is it?
Serous fluid.
It's serous fluid. What do we call it? Pleural fluid. So that fluid is going to help maintain pressure within that cavity as well, that pleural cavity. Why is the left lung a little bit smaller than the right lung?
Because there's a heart
That big old heart's there. Yes, exactly. So the left lung is a little bit smaller and has 2 lobes rather than 3 lobes that the right lung has. Very, very highly vascular. Why is it very highly vascular? Exactly, because we need lots of gas exchange. The more blood vessels I can have for gas exchange, the more efficient gas exchange I can have. So it's highly vascular, and we see some main branches feeding into the hilum of the lungs on the side in this diagram. Some major arteries and veins. What are those major arteries and veins called? You know this for your test. Major arteries and veins.
Major artery is pulmonary veins.
Pulmonary artery, pulmonary veins. Yes? Remember? Because that's part of your path. You better remember it, girl. That's part of your pathway.
Yeah, I know it that way, but not that way.
Yeah, the pulmonary circuit, exactly. So pulmonary artery, pulmonary vein. That's going to bring blood from the heart to the lungs. Branch, 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 and we see them all there. I'm not going to make you memorize them. You can do that when you take another class or become a respiratory therapist. But all those vessels have different names, yes, just like all the vessels that we didn't study in the circulatory system. And then they're going to flip back after gas exchange, and they're going to come back to the heart via the what? Pulmonary veins. Not superior and inferior vena cava, because now we're in the pulmonary circuit, so we don't have to go back there, right? Because where are we going to go back to the heart? We're going to go, no, I hope not, go back to the heart. The left atria, correct? So we're going to come from the right ventricle out the pulmonary artery to the lungs, gas exchange, come back, pulmonary veins to the, which part? Left atria, yes? So that's part of, you need to know that. So we see how vascular that is. So, gross anatomy of the lungs, we talk about some of the different segments. The branching of those trees is very, very specific. Each of those branches is going to feed a very specific area. There's different segments that those branches go to. One of the nice things about the lungs is there's so many different ways to get air to the lung tissue. So if something happens, if I have to remove a piece of lung, I have so many other places for gas exchange. Okay? If an area gets damaged or if an area has to be removed. So we get an appreciation when we look at this diagram for the bronchial tree, how many different branches we have. We have the different lobes, we have different specific bronchi that feed those specific lobes.
Which part of the lungs is more important? Left one or right?
Both are just as important. So say you lost some function.
Delete part of the lungs.
It's like saying which kidney is more important.
Yeah, but maybe it's like right side is more important because there's 3 lungs. No.
Okay. They're both as vital, one or the other. It just depends on if I had to have, I don't know.
Choice to remove one or
No, you would choose not to remove either. But you have a lot of options for gas exchange, which is a good thing in the lungs. If something happens, they talk about different segments in different areas. Bronchopulmonary segments are what each of our tubes are feeding into. Smallest subdivision of the lung is a lobule. And then blood supply and innervation of the lung. Don't worry about that. You know the main arteries and veins, pulmonary vein, pulmonary artery. We have bronchial circulation, bronchial arteries as they get smaller and smaller. Let's pick up a week from today with the pleura. And you have an exam on Tuesday, and you get to go on vacation. So,